We also performed another randomized control study in cooperation with New York State University in Buffalo by comparing two groups of patients, one called the early treatment group, in which the angioplasty was performed at baseline, and the second group of patients in which angioplasty was delayed at 6 months. This study demonstrated that balloon angioplasty is safe and well tolerated, and so confirmed the safety of this kind of treatment. Rate of restenosis was 29% in the internal jugular vein versus 0% in the varigose vein. And very important, we found a significant decrease in the number of T2 lesions blindly measured by the means of MRI. And this also confirmed that this kind of treatment is protective for multiple sclerosis patients. My conclusion are that CCSVI exists and is a serious obstruction, a major vascular problem, whether the patient has multiple sclerosis or not. CCSVI is significantly related to multiple sclerosis patients at different latitude and on different genetic background population. Angioplasty corrects the blood flow from the brain, and really, the correction helps people with multiple sclerosis. I think that it is not responsible not to proceed with angioplasty treatment of CCSVI in patients with multiple sclerosis under the umbrella of clinical studies supervised by ethical committees in tertiary hospital and with all the capability in interventional radiology and in vascular and endovascular surgery. Thank you.
We will now move to Dr. Simka.
Good morning, ladies and gentlemen. First, I'd like to thank you for the kindly invitation for this conference. I represent the center, this Euromedic Specialist Clinic in Katowice in Poland, that I believe has performed the largest number of endovascular treatments for chronic cerebrospinal venous insufficiency in the world. Although we only began those treatments in October last year, we currently perform about 20 procedures per week, and total number of people who have been treated is now about 400. It's important to point out that the interventions for these venous problems in our department have been approved by the Bioethical Committee of the Regional Stylism Board of Physicians in Katowice in Poland. Because we collect all data regarding patients' history, clinical status, and the characteristics of the venous lesions that have been diagnosed, the analysis of this data set has enabled us to draw some conclusions regarding links between CCSVI and multiple sclerosis, and also regarding the safety of the treatment. First, CCSVI has been found to highly correlate with multiple sclerosis. Only 3% of the multiple sclerosis patients we have seen were not diagnosed with CCSVI using color Doppler sonography, magnetic resonance venography, and standard venography. Secondly, localization and severity of venous lesions have been found to significantly affect the clinical course of multiple sclerosis. For example, injury to the optic nerves were found more often in the cases with unilateral lesions in the internal jugular veins, while bilateral stenosis in the internal jugular veins correlated with a less frequent ocular pathology. More disabled patients were found to suffer from bilateral and/or severe occlusions in the internal jugular veins, and the patient with stenosed azygous vein presented with the most aggressive clinical course of the disease. This findings, in addition to primary observation that a substantial percentage of multiple sclerosis patients improved after endovascular interventions, favor the idea that surgical treatment for those venous obstacles should be an important part of the management of multiple sclerosis. The most important question regarding treatment for CCSVI, however, regards the safety of such a management of venous outflow blockages. Such a management strategy is actually recommended by the consensus document of the International Union of Phlebology, as has been mentioned by Dr. Zamboni. However, although similar endovascular procedures for the treatment of other venous pathologies or arterial pathologies are known to carry very low risk, an actual rate of complications related to such treatments for CCSVI remains undetermined, mainly because these procedures are not yet routinely performed in these cases. Moreover, recently in some neurologic papers, it has been claimed that surgical treatment for CCSVI can be dangerous. Interestingly, those statements were based only on the beliefs of the authors and not on the body of evidence. Contrary to those opinions, in our clinic we have demonstrated that these procedures are safe and usually well tolerated by the patients. In the group of 347 CCSVI patients with associated multiple sclerosis that have undergone a total of over 500 endovascular procedures, including 414 balloon angioplasties and 173 stent implantations. And these procedures were performed during 341 interventions. And in this group, there were only few rather minor and occasional complications or technical problems related to the procedures. Regarding life-threatening complications, there were no death, no major hemorrhage, no severe stroke, no migration of the stent. Regarding major complications, there were only 2 airy stent thrombosis. In 2 cases, there were false aneurysm in the groin, but this was successfully treated with thrombin injection. In 1 case, it was necessary to open the femoral vein to remove the balloon. There were no injury to the nerves. Regarding other minor complications, there were some cardiac arrhythmias, some minor bleeding from the groin, gastrointestinal bleeding, lymphatic cyst, and some technical problems. But all these complications were rather minor and they did not produce more problems in the future. Therefore, in our opinion, precise preoperative diagnostics, this should, in our opinion, consist of color Doppler sonography and magnetic resonance venography, and also selective use of the stents if balloon angioplasty is not successful can make the endovascular management for CCSVI free of significant complications, and in terms of restoring the proper venous outflow, even more efficacious than performing balloon angioplasty in all cases. However, the actual impact of the endovascular treatments for venous pathology on the clinical course of multiple sclerosis warrants more clinical studies and longer follow-ups. Thank you.